This motion picture was made to show you a system for treating carious primary teeth, which is based upon sound diagnostic and biomechanical principles. The operation begins with careful, complete, and accurate examinations, diagnosis, and treatment planning. This is followed by a conference with the parent to inform her of the dental needs of her child and the proposed plan for taking care of those needs. The explanation is made clearer and more effective by projection of the patient's radiographs. Models, pictures, and other teaching aids are used when needed to help the parent understand the child's problems and what is recommended for treatment.
The parent is told of her child having many cavities in the sides of the teeth where they touch each other. These can be treated in many ways. The usual one is to grind away part of the tooth around the cavity to form a box-like hole for receiving a filling of silver particles and mercury called amalgam. This hardens in a few hours after it's been placed. This type restoration is a good one, but modern dentistry has developed better ways specially designed for primary teeth that takes less time for the patient and for the dentist. The modern way requires less cutting of sound tooth substance than the amalgam and yet is stronger and more protective. These facts are important because primary teeth are so small and their pulps are so large there is little tooth substance available for making box-like cavities deep enough for the construction of strong amalgam fillings. The cast silver or gold restoration does not require a deep box-like hole in the tooth to help keep it in place. As it is cast in one strong piece before it is cemented to the tooth, it actually supports and helps to strengthen the remaining tooth rather than weakening it. The casting is designed mechanically to encircle the tooth, gripping the sides, and to dovetail into shallow retentive grooves. When the finished restoration is sealed of the tooth with dental cement, the patient will have a strong filling which reinforces the tooth, protects the pulp, and prevents further decay in the covered shallow grooves. The happiest part is that this operation not only saves teeth, but it also saves time, the patient's and mine. Fewer visits are made to the dental office and more patients are treated in the time saved. The end result is an exceptional dental service for only a slight increase in cost. This is more than offset by the greater ease, rapidity, safety, and comfort with which the child's case is handled. In fact, the total cost may be less in the long run than with other methods. Because the castings are stronger, they rarely break, they restore the full contour of the teeth, they protect the gums, there are fewer pulpal complications, less future decay, and less of parents' valuable time is spent in the dental office.
The actual operation begins with a red compound preliminary impression taken in a Willet tray. The warm compound is forced down over the teeth and moved slightly from side to side to enlarge the impression. When the compound hardens in the Willet tray, it is used for the final impression. It is dried with air and painted with adhesive. Only the thinnest possible film is applied that will give a glossy surface. The final impression will be inaccurate and will tear easily unless the adhesive film is very thin. The impression is turned upside down to allow excess adhesive to run away from the operated areas. The methods and instruments recommended for cavity preparation are those that best meet all biologic and mechanical requirements. It is essential that the instruments used cut enamel easily and that changes be few. Only 3 cutters are used. The number 70L burr or diamond equivalent in an air rotor handpiece, then a mesial and distal half-inch diameter perforated disc in a conventional handpiece, rotating slowly under a water spray. As carious lesions occur in the distal surface of the first molar and the mesial surface of the second molar at the same time, careful examination will usually reveal cavities in all these teeth when a lesion is found in any one of them. After locating all teeth requiring treatment, time is saved by careful planning and by operating the teeth in one or more quadrants during each appointment. The burr in the air turbine handpiece is used for most of the cutting. The perforated discs smooth and perfect the proximal surfaces and margins. Sharp, straight, easily seen margins aid the technician in die trimming and preparation of the wax pattern. The dentino enamel junction is most helpful as a guide to cavity depth if no anesthetic is used. The preparation is cut no further than 1/4 to 1/2 millimeter into the dentin. The deepest cuts are on the occlusal, where most dentin is present and where greatest depth is required. The proximal slices and axial grooves must be shallow, as some primary teeth have only 1/2 millimeter of dentin around the pulp in the middle and cervical thirds. The buccal and lingual grooves are extended as far gingivally as possible. Their depth and width are governed by the mechanical requirements of waxing, casting, and retention. The dentino enamel junction is used again as a safeguard against excessive depth. The proximal slices are made simultaneously on both molar teeth. The burr is held at right angles to the occlusal planes, and equal amounts are removed from each proximal surface by carefully traversing the interproximal space. When the burr is held correctly, smooth, shallow slices are formed without shoulders on both molars. The occlusal, lingual, and buccal cuts are made with the same burr. Extension for prevention and for retention are the principles which govern the design of these cuts. Depth is measured again from the dentino enamel junction, which also serves to guide the burr up and over cuspal and marginal eminences. The operator must understand that shoulders, flat floors, undercuts, deep boxes for retention, and other dentin sacrifices essential for retention and support of amalgam are undesirable and unnecessary when silver castings are used for primary teeth. The correct cavity outline follows nature's pattern, conserving dentin and preserving pulp health. The cast restoration grips the outside of the tooth for retention rather than locking inside deep boxes cut within the dentin. The axial and occlusal grooves may be cut less deep when 22-karat gold is used for casting instead of the silver ingots. Gold is preferred for those cases with very small molars or extra large pulps. Casting golds harder than 22-karat plate are not recommended for restorations of this type. The proximal slices are smooth and the margins are sharply defined with small perforated diamond discs revolving at slow speeds under a spray of water. The handpiece belt is adjusted very loosely so the disc will not jump to the soft tissues should it catch between the teeth. The patient is protected further by a metal mirror guard for tongue and cheeks. Carious dentin is removed after the final impression is taken. The gingiva is shrunk with a hemostatic agent, a string impregnated with racemic epinephrine. The average time required for the entire operation, cavity preparation, and string packing is 6 minutes. 2 quadrants are completed in a 40-minute visit, or 4 quadrants in a 1-hour visit. During the time the gingival packing is taking effect, the patient rests while the dentist treats another patient in another room. The string is removed and the area dried after 5 minutes have passed. The area must be absolutely dry of saliva or blood before and during the time the impression material is mixed and used. The syringe is loaded, the tray is filled and pressed to place in the mouth. An assistant holds the tray in position while the operator and second assistant continue with the second patient in the other room. After the impression material has set, it is removed, washed, dried, and carefully inspected. While the assistant mixes the temporary cement, the operator removes the remaining carious dentin with sharp spoon excavators. Burrs are not recommended for this purpose. Deep carious lesions are lined with calcium hydroxide and zinc oxide eugenol. This temporary restorative material is used because it prevents drifting of the prepared teeth, is easy to remove, and does not make the teeth sensitive. The temporary cement is mixed to a thick putty consistency. It is forced between the prepared teeth and into the cavities. Excess is trimmed away with a plastic instrument. The child is then asked to bite and chew. Excess is removed again, and the patient is dismissed. The most laborious and exacting parts of this operation are performed by auxiliary personnel. The time saved by the dentist is spent in treatment of more patients. Mass production techniques allow these restorations to be made at a cost which is acceptable to the patient and profitable to the dentist. When volume output is maintained, the restorations can be placed for the patient for a fee that compares favorably with that usually charged for amalgam. The technician accumulates several impressions so that they may be poured at the same time. They are washed, dried, and painted with a layer of Ransom and Randolph dye stone. Fewer bubbles and a denser cast are obtained when the stone is mixed and poured under vacuum. After the impression is filled, it is placed upside down, parallel to the table, on a small mound of soft stone with the patient's name on a piece of paper. After the stone has set thoroughly, the impressions are removed gently. The casts are trimmed by grinding the base parallel to the occlusal plane. The remaining 4 sides are trimmed parallel to the opposite side. The flat, smooth surfaces provide planes for easy realignment after the casts are sectioned. When the casts are dry, they are carefully sawed to within 1/8 inch of the base with a thin blade in a moto saw. A slight squeeze breaks the cast so that it can be accurately reassembled. A soft nylon toothbrush is used to remove the dust. The gingival margin is established precisely by trimming at a 45-degree angle with a number 600 Fisher burr in a straight handpiece. It is marked also with a pencil as a further guide to the technician. The casts are painted with separating solution. J.B. Moyer's bulk green inlay wax is the easiest to remove from the die without distortion or breakage. The groove, cut in the model with a number 600 Fisher burr, provides a finishing line for a thick wax pattern at the gingival. This allows complete restoration of full enamel thickness in the cervical area, as well as accurate castings. Correct contour is essential to gingival health. Patterns are polished with a very soft nylon toothbrush and sprued on the contact areas. The sprues serve as handles for removal of the patterns. This operation is delicate, as the tiny, thin patterns are easily distorted. are placed in clusters on crucible formers and painted with debubbleizer. Unlined rings are used for silver castings and asbestos-lined rings for gold. The rings are placed over the patterns. Silver ingots must cast into a cavity that is 1/4 of an inch or less from the investment surface at the end of the ring. It is sealed tightly to the crucible former with sticky wax in order to prevent leaks. An indelible pencil is used to mark the inner surface at the correct height for the investment. The investment material is mixed in accordance with the manufacturer's directions. The ring is partly filled using the vibrator. Patterns are painted with investment, and the rings are filled to predetermined height. Vacuum aids in eliminating bubbles on castings. The rings are placed in a cold oven. Temperature control is adjusted to produce 750 degrees for silver castings. The rings are held at this temperature for at least 1 hour or longer if desired. If an electric crucible is used to melt the silver casting alloy, it is adjusted to 1500 degrees Fahrenheit. New alloy melts at approximately 1300 degrees. The machine is set somewhat higher because old material is usually mixed with a small amount of new. If the alloy is not overheated, it may be used again. An ounce of alloy yields about 50 restorations. It gives accurate, dense castings which are easy to finish and polish. When gas and air are used to melt metal, care must be exercised to avoid overheating. A brush-type flame is used. The metal is heated just enough to make it ball, not until it shines like gold. After casting, the inlays are cleaned thoroughly with brush and water. Sprues are clipped, and a small gold finishing burr is used to remove bubbles or irregularities. The castings are seated gently on the dies and finished with stones. Finishing burrs and sandpaper discs. This is an important step. The technician is taught to leave enough metal for the dentist to adjust contact zones, mesiodistal widths, and tooth contours in accordance with the special requirements of the patient and his dentition. Grooves in proximal areas are polished with bristle brushes, white Tripoli, and Sure Shine. The second operative visit should be within 4 or 5 days after the first, in order to avoid undesirable tooth movement. New preparations are begun unless all carious teeth were prepared during the first visit. After preliminary impressions have been made for the new work, the temporary restorations are removed with explorer and aspirator. The area is cleansed with warm water to remove small particles. Castings are placed on the teeth one at a time. Contour and contact zones are studied carefully. They are shaped to fit the individual needs of each case. Contacts may be fitted snugly, but they should never be shy. Occlusion is checked with marking paper and by looking at critical points when the child closes and chews. The greater part of the marginal adaptation is done with rotating stones and gold finishing instruments. They are pulled or pushed along the margins using the tooth surface as a guide. Finishing stones are revolved in the direction of the margin runs, never across it from metal to tooth or vice versa. The inlays are cemented with crown and bridge cement. The whole area is covered with dry foil, and the next quadrant is then operated. After the preparations are completed, the dry foil is removed and excess cement is picked and washed away. The seated inlays are polished with pumice and amalgam. This is done easily and quickly, as most of the polishing is completed by the laboratory technician. The polish lasts in the mouth without tarnish. The finished restorations seldom break, and recurrent caries seem to be inhibited. In scheduling the work to be completed by the operator at each visit, 1 1/2 minutes are allotted for seating the inlays to each minute that is given to preparations and impressions. All procedures, chairside and laboratory, must be organized and executed in a systematic, efficient manner. Patients are recalled at regular intervals of 4 to 6 months for x-rays, periodontal treatments, and preventive therapy. New lesions and marginal defects can be restored with more castings or amalgam. When amalgam is used next to a silver casting, the metals seem to join perfectly. A review of the entire operation brings out the following points. The most important consideration is to unite modern surgical techniques and established biomechanical principles in a system of operative dentistry which better satisfies the special requirements of primary teeth and the children who bear them. The child today is entitled to an exceptional dental service, one that is comfortable, rapid, economical, safe, and healthful. The tiny primary teeth with large pulps and little dentin anatomically and physiologically require restorations that conserve rather than sacrifice tooth substance. Such restorations strengthen weak teeth, protect pulps and gingiva, prevent decay, restore full contour, and save time and money for all concerned. These advantages are made possible by carefully systematizing all procedures and judiciously delegating work to chairside assistants and to laboratory technicians. Mass production techniques lower costs and increase output. Finally, this system diligently practiced enables the dentist to provide a superior service for more patients in less time.